All right, so with that, I'm going to move on to the next part of my talk, which is discussing acid-base status in these patients. So again, what is the problem of dialysis patients? Dialysis patients develop metabolic acidosis, and we know that happens because as the nephron mass declines, as these the patients lose functional ability of the kidney is not able to do what it is supposed to do, which is regenerating new bicarbonate and restoring or reclaiming the filtered bicarbonate. All right, so these patients end up having metabolic acidosis because of that results from accumulation of protons that result from metabolism of proteins that we eat in the diet. All right, so that would be the mechanism for developing metabolic acidosis in dialysis patients. So for a long time we have known that metabolic acidosis is not healthy, in dialysis patients. There are some nutritional consequences, all right, such as catabolic effects, anti-anabolic effects, insulin resistance, systemic inflammation. We've known for a long time that these patients are more likely to develop bone disease, and that is because of buffering of the acid that takes place at the bone, where bicarbonate is leached out, as well as calcium, because these bones become weaker. There's some indirect effect, related to PTH and decreased activity of 1-alpha hydroxylation. And there are some systemic effects, such as increased generation release of beta-2 microglobulin and hypertriglyceridemia. So there are some harmful consequences of metabolic acidosis. Now, the next question is, how common really is metabolic acidosis in dialysis patients? And this was a large study from one of the large dialysis organizations in the USA, where they just looked at the time average serum bicarbonate, all right? 10,000 patients on PD and more than 100,000 patients on hemodialysis. So if you take a cutoff as 22 there, so if you look at the right part of the graph here, the black bars being PD and the white bars being hemodialysis, so you could conceive, or you could notice that PD patients are more likely to have higher bicarbonate than hemodialysis patients, all right? So in this particular study, only 60% of hemodialysis patients and 75% of PD patients had a time averaged bicarbonate that is equal to or more than 22. So really, dialysis is not that good enough. It does not get the bicarbonate in all of these patients, all right? What also this study found out was that severe metabolic acidosis, meaning bicarbonate less than 19, was associated with significant increase in mortality in both dialysis populations. So again, I just want to caution you that this is observational study. It cannot prove causation, but it's just hypothesis generation. We could hypothesize that metabolic acidosis is bad. And if it's severe, that could result in higher mortality in these dialysis patients. So this was another study that looked at time average bicarbonate and correlated that with the probability of patient survival on the y-axis there. All right, so they classified patients into three tertiles. The top green line, blue line is total average bicarbonate that is equal to or more than 24. The green is 22 to 24, and the red is less than 22. All right, so what you could clearly see that time average bicarbonate, the higher the time average bicarbonate, the more likely that these patients are going to survive, and vice versa. All right, and this study had tried to adjust for multiple things, as you can see there. All right, and really the final conclusion of the study was that compared to patients with a time average bicarbonate more than 24, those with less than 24 had a progressively increased risk of death. All right, so perhaps we should try and achieve a bicarbonate that is 24 or higher in our PD patients in order to decrease their chances of mortality. Again, this is observational data that is just hypothesis generating, but that's what we have. And again, all what I'm showing you right now is our studies that are, focused on PD patients, not general dialysis patients. All right. So the conclusion is that low bicarbonate seems to be an independent risk factor for mortality in these patients. The relationship between low bicarbonate and adverse outcome could be because of enhanced inflammation or because of more rapid loss of residual kidney function. And it appears that PD patients should try, we should try to achieve a bicarbonate of at least 24 or higher.